Welcome to the Java Cafe, Java fam.
Oops, might need some sound. Good morning, everybody. Good morning. Good morning. You are tuned into another episode of Your Healthy Job. And let's just get the music there. Let's get this one there. Good morning, everybody. Just a little off with the tech this morning, but we are here this morning to talk about a subject that I got clarity about in putting this episode together. We're talking about palliative care. And in the advertisement, I put palliative care and also senior care. And I'm learning in real time that they are not the same thing. And we have Dr. Davala with us, who is going to tell us more about palliative care. We're not going to talk so much about senior care this morning. And for those of you that were tuned in about that, we will pick that up in our next season of Your Healthy Java. But palliative care is important. A large number of seniors are in it. But we're going to learn about what it is, what's the difference maybe morally between palliative care and hospice. And so I am honored to have this wonderful woman here with us this morning. I got to meet her some months ago when we did the first live Your Healthy Java at Dudley Cafe. I believe it was definitely last year. And so I would like to introduce to some and present to others Dr. Kareen Davila. Davila, I got it on the last try. But names are definitely important. So welcome this morning. You're not a stranger to the Java Cafe, but please say good morning and greet the folks. And we'll jump right in.
No, good morning, Jimmy. Thank you so much for having me this morning. I'm excited to be here. I know it's hard to believe we were at the Dudley Cafe. It was last September.
It was
Uh,
September.
it was September. It was for Latino Hispanic Heritage Month. So it was
Yes.
September. So well, late it goes it's one of those months that's a little bit odd. You
In
don't
the,
actually get a full calendar month. You get
yes.
September 15th to October
Like
15th.
that's what I
So
thought.
maybe we'll call it October and then it won't feel that long ago.
Okay, that's a little more up to date with us, but I am excited to have you here because I learned a lot from you. And it's funny because in remembering in real time, we did sort of discuss a little bit of the difference between your specialty and also senior care. But before we jump into that, why don't you tell us a little bit about yourself, why you chose this specialty, and then we'll go from there.
Yeah, sure. I am happy to share a little bit of my story. So, Jimmy, I was someone actually who didn't have doctors in the family. And at the same time, when I moved and got a new pediatrician, I was 6 years old and decided I wanted to be just like her when I grew up. And so I wanted to be a doctor since I was 6. I wanted to be a pediatrician, and now I'm not a pediatrician, but that's okay. Um, what what was important or why I share that story, and I feel like that's an important part of me, is part of why I really identified with my pediatrician and wanted to be just like her was because she was also a Latina woman who spoke Spanish. And that is just powerful. And so I feel like my own story is one of why representation matters, because if I didn't have her in my life as an example, I'm not sure that I'd be where I am today and in this position. Because, like I said, I didn't have any doctors in my immediate family or see that example kind of growing up, but she inspired me, and I was like, I want to be just like you. Um, so I have that interest and passion in kind of medicine and helping people started really young. And I also had no idea what palliative care was for first couple decades of my life. I didn't even know what it was when I applied to and started medical school. But on my very first day of medical school, um, our medical school did this kind of crash course or like intro to emergency medicine that they did over our first 2 weeks of medical school, because they're like, people are going to hear that you're in medical school and they're going to assume you know things. And let's be real, you don't know anything yet. You've just started. But let us sit down and give you kind of just a few basics in this 2-week intro crash course in case you find yourself, I was going to med school in New York City, in case you
Is
find
there a
yourself
doctor in the building?
trapped in a subway car that's like stuck between stations
Oh yeah.
and like everyone's like, is there a doctor that you could maybe know a couple of things to try to help in the setting of an emergency? And I remember my small group leader, we had these big lecture, but we also got split into small groups. And my small group leader was an emergency medicine palliative care trained physician. And I was like, what's that? So just to share with you and share with your audience again, palliative care is a specialty of medicine that helps people with serious illness
Okay.
at all stages. So like from the time of diagnosis all the way through end of life.
Okay.
And
So
we really kind of like help in three main ways. The first one is around symptoms like pain, nausea, things like that,
okay.
trying to help people feel as well as they can. The second is really trying to provide some support and often being a sounding board for decisions that come up over the course of illness. Um, and sometimes it's kind of even making sure that you're getting all the right information that you need to be making decisions. Because that's, as we know, we talked a little bit about communication last fall, not always the easiest thing to do. And then third, really just to kind of be an extra layer of support to patients, families, teams taking care of them, and things like that.
we're definitely jumping in. Naraki, who's listening over on LinkedIn, Naraki, I see you're having some issues with Facebook. And thank you for those of you that are watching on LinkedIn or on the website. And we're going to, Dr. Davila just talked about it a little bit, but there is, I think this, but I'll say that I had believed that it was morely seniors and it was morely those who were at the maybe end stage of chronic disease, which maybe we can clarify the difference early on. That may be more hospice. And let me ask a clarifying question. Getting into palliative care, does that mean that you are in any sort of stages toward heading toward hospice rather, or is it just management, like you said, from the time of diagnosis until they don't need the services anymore? Or can we sort of, and not to be,
Yeah.
morbid or anything, but clarify the difference between the two?
Yeah, no, it's a really good question and one that I get asked a lot. And I think that's a common a common question or fear. I think, many times people hear palliative care and they immediately associate it with hospice.
Okay.
Because if you probably put out there what's kind of more common or well known, I bet you hospice is probably a more recognized
Yeah.
term than
Yeah.
palliative care.
Yeah.
Um, and so hospice is, I would say, palliative care is kind of an umbrella over the continuum of care that I described, kind of from the moment of diagnosis through end of life. And I'll even just share, like, even kind of the moment of diagnosis, that can be fuzzy for some things. I would say palliative care kind of grew up hand in hand with oncology and with patients with cancer. Um, it's more defined, right? There's one day that you don't have cancer, and at some point, one day you get diagnosed with cancer. And
Yeah.
so that time of diagnosis might be more clear defined. Whereas for a lot of other illnesses, it's not so black and white. It's not like one day you don't have a serious illness and one day you do.
Yeah.
Some of the things that you're describing, like just having a lot of, um, chronic illnesses at some point, when those start adding up, we might say, you kind of have a serious illness and it might not be any one thing that we can pinpoint, yesterday it wasn't a serious illness and now it is.
Mhm.
And so I think that speaks to this idea that a lot of people can benefit from palliative care much earlier. And so, to answer your question, hospice is one of the things that we do under the umbrella of palliative care.
Really?
And hospice, and so, for example, when folks get specialty training like I did, it's really in the name of the fellowship program is actually hospice and palliative medicine.
Okay.
And so we kind of call it palliative care a little bit more colloquially
Yeah.
amongst us. But hospice is focused on individuals for whom kind of um, getting more disease directed treatment. So if we stick to the theme of cancer for a second,
Yeah.
for whom kind of getting further cancer directed treatment either isn't an option or isn't the right choice for them,
Mhm.
then that's an appropriate time oftentimes to be thinking about hospice. And there's a lot of history that you can talk about the hospice benefit, but I'll just say briefly, it kind of first came about with Medicare rules back in I think it was the 70s. Um, and it was intended to focus and support people who, from doctors' best guess,
Mhm.
have about 6 months or less to live.
Okay.
But I'll touch on that hospice bit. And again, it's our best guess, right? Doctors can definitely be wrong sometimes. So
Yeah.
I've definitely taken care of patients before who, again, with doctors' best guess, they kind of, it was in alignment with what those person's values are. They kind of, signed up for hospice. And then we're on hospice for like a year, a year and a half, sometimes 2 years. Granted, if people are
Never know.
actually doing well and it no longer seems like they kind of meet that gestalt feeling of probably 6 months or less, you actually have some folks who graduate from
I
hospice
was going to
and who
ask, do you
you do.
discharge people?
So there sometimes, I will say
Okay, yeah,
it's not common. Um, but sometimes people do graduate from hospice,
wow.
and then they're kind of going on and living their lives, and it may be at a certain point down the line they're once again a candidate for hospice, and that may feel right to kind of choose that again. But
I
I would say in general, oftentimes I experience that people are choosing hospice actually really late, and the average length of stay on hospice, like the amount of time from enrollment until the person dies,
mhm.
is quite short. Honestly, like I think the national average is something like a week, and I think
I
that
yeah,
is in general hospice, in addition to palliative care, is probably a really underutilized benefit, and I think
and that's one of the
oftentimes
things we're
people
gonna
wait
jump
till too
into.
late. I'm
Yeah.
sorry, I'm
Yeah.
too chatty, I'm not even
No,
letting you
you're
get
good.
a word in.
Dr. Oliver, you're good. But no, the audience is agreeing with you. I'm so grateful for palliative care staff at Beth Israel during my dad's transition in 2014. I was out of my mind, and they were supportive and connecting me to in-home services and safe spaces and caregivers. Marie Doubleday says my mother was with stomach cancer, and to your point earlier, was given 3 months to live. She lived 3 years. And
Yeah.
so that they are definitely affirming everything that you're saying. But you did touch, because I do want to Asia's point, and you kind of began to touch on it. What are the benefits of getting into palliative care?
Yeah. So, I mean, I think the benefits are, um, let's stick with the example of someone like a patient who has cancer.
Yep.
That's in some ways maybe like the easiest example.
Yes.
And so oftentimes what will happen, or how we can be helpful even from as early as kind of the time of diagnosis, is we really help support patients and families in a number of ways. I mentioned like helping them physically feel well, and so sometimes it's, for example, symptoms of the cancer, or because of the cancer they might be having things like pain, nausea, constipation, or things like that. And so we are often an extra set of eyes and ears, and we're kind of symptom management experts that support the oncologists who, rightfully so, are spending so much of their time and energy figuring out, how are we managing this cancer?
Mhm.
And so when we're part of the care team, we can take a little bit of that pressure off of the oncologists and say, we'll take the ball on some of this symptom stuff. Like we'll help support some of the pain management and let you focus more of your time and attention on the pure cancer part, and we will help with the pain and symptoms, for example, that, and sometimes it's because of the cancer, and sometimes, as your listeners or kind of may have seen either for themselves or for other family members living through illness, sometimes it's the treatments themselves,
Yeah.
things like chemotherapy and
Yes.
radiation, which are also contributing to symptoms. And that's also something we can help with, no matter what is causing the symptoms, be it the disease itself or treatments for the disease. We help patients feel better so that they feel better, they get more rest, they're more up for continuing their treatments, and so oftentimes having their symptoms under control helps them engage and continue receiving treatments for better or for longer or things like that, than if their symptoms were so uncontrolled that they're like, no, I'm done, I can't do this anymore.
Absolutely. And I'm hearing from you two things, from being in the medical industry and then also being a caregiver for a few folks, you all are really managing sort of the day-to-day quality of life as a part of a care team, either through oncology, cardiology, in some cases, people that may have congestive heart failure or different things like that. And so I remember we used to have, and I don't know if they're still around, but nurse case managers
Mhm.
that would, and I'm sure you probably have them, may have them there with you, but it really is encouraging to know that the getting clarity about this specialty, that it is really around comfort and coordination. If I'm hearing comfort and coordination for the patient from a very layman's interpretation, am I right there?
Yeah, I mean, I think that's right. And what's funny is, Jimmy, I've actually done some research with an awesome organization. It's called the Massachusetts Coalition for Serious Illness Care,
Mhm.
which is kind of a group of they're not patient facing. They help kind of organize a lot of organizations who support
Yeah,
people and
yeah, yeah.
caregivers kind of going through or experiencing serious illness. But they've actually done some research and some testing, and they've kind of tested this language of palliative care to for people who are unfamiliar with it, of like, if you had a team who did some of this and they describe some of the things that palliative care does, people think it's too good to be true. They're like, how much would that cost me? Is that really a thing? Like, and we're like, yeah, it's a service that you can kind of, ask for or engage, that, is covered by insurance. It's not like an out of pocket cost to you.
It's so we often, and and you address this in spaces academically and there, we often talk about disparities in
Hmm.
healthcare. Awareness and information is one thing that we're accomplishing now, but access is also often an issue. And I believe that it's important that we reiterate, however you would like, that this is a service and also it is covered. It's not, I don't want to, we're not putting words in your mouth or saying that there may not be any cost or, there are co-pays and things that come up like that.
Sure.
But I just really think it's so important. I'm seeing that some folks were familiar with it in here, but making sure that folks know that this is an available service with that, and kind of understanding that there is a large percentage of folks that are dealing with chronic diseases that may need to consider advanced planning.
Hmm.
With this information and awareness, it is up to the patient whether they want to or not. And sometimes certain diseases cause folks to become what's the word, decompass they can't, they can't, either they're unconscious, capacitated,
Oh, incapacitated.
incapacitated. Thank you, that's why you're the
Yeah.
expert, as I said yesterday. You're the expert. And so let's talk a little bit about a patient's thinking or approach to making their wishes known to family around palliative or hospice care.
Yeah. No, it's such a good question, Jimmy. And kind of what you're talking about is this kind of broad bucket of activities that we call advanced care planning,
Mhm.
of thinking ahead and maybe having an opportunity to not only communicate the things that are important to you, communicate if you have specific wishes with, with family members or whoever the, support members in your own kind of personal life, be
Yes,
they family through blood or through chosen family. Um,
that part.
Uh, th so and importantly, with your doctors and your
Yes.
clinical team so that they know what's important to you. Um, so, I think one of the analogies that I really like, about palliative care is some folks who are familiar with it, like I said, they kind of link palliative care and hospice, even though we talked about palliative care can be really helpful long before you're even potentially a patient for hospice. And so we can be supporting patients through, for example, their cancer journeys for actually years before they're even kind of maybe ready for hospice or
Mhm.
even appropriate for hospice if that's the right thing. And there's also people who, we're caring for with cancer. We talked about graduating from hospice, for some folks who, are going through their cancer journeys, they achieve remission or even cure from cancer and they stop needing palliative care. So they graduate from palliative care too. That's not everybody's journey. Everyone
Yeah.
has their own disease journey, but I just want to reinforce it's like going. engaging with palliative care, like, isn't a death sentence. We're here to support. And one of the analogies that I really like is, um, you can kind of think of palliative care like an umbrella. It's often associated with rain, and nobody likes rain, right? Um, but if you don't like, if you don't get palliative care, you might be at some point stuck in a rainstorm and you're like not ready. And it just all of a sudden hits you down and you're soaked to the bone and everyone's like, oh my God, what do we do? And it just feels like a crisis. But if you are introduced and able to engage palliative care early, it's like having an umbrella. An
Yeah.
umbrella might make you think of rain, but it's not the cause of rain. It's just kind of something there. It's a safety net that you put in your purse or put in your backpack so that if that day when that maybe unexpected rainstorm comes, you have a team and you have tools and you've had conversations so that you're ready to whip out your umbrella and you don't get soaked from the beginning.
And that so you're talking to a faith-based, grew up in a black church a person here, and you just preached about the umbrella. That analogy was absolutely amazing. And so it's a protective, all right, so it's a protective layer of care that coordinates and causes you to be more comfortable as you're dealing with the diagnosis.
Mhm.
It's very, very simply to put it. It's just I'm learning a lot here myself. You
Yeah.
mentioned
I didn't I'm sorry, Jimmy. I keep having these thoughts and I keep not actually answering the direct question you
no,
asked
no,
about access and inequities in access too. So we can definitely talk about that
we're
as well.
we're going there, and let's mix in a little bit of what is it that people can have access to as far as the resources. You've named some, but let's talk about, access and the fact that a lot of people, and with everything that a lot of BIPOC patients deal with, this is yet another layer of protection to ensure that there is good coordination for the day-to-day quality of life for the patient. And so let's talk a little bit about, sometimes limited access and how folks can access the resources.
Yeah, no, it's a great question. And so palliative care can be delivered in different care settings. So I would say the most widely available place that you can get palliative care is typically in the hospital for hospitalized patients, or what we call the inpatient care setting. Um, I want to say, I think in terms of large hospitals across the United States, more than 90% of them have an inpatient palliative care team. It's some a little bit less available in some smaller hospitals, and we know that there's a number of challenges in terms of, rural America getting access to care, getting access to specialty care is a limitation. So I can't say it's available in 100% of places, but especially in a place like Boston, I think we're like really lucky that we have so many awesome big um,
Teaching.
hospitals that have palliative care. And so if you or a loved one kind of is admitted to the hospital, if you're like worried about be it cancer or other diseases or things like that, it's always something that you can talk with your care team about of, might palliative care be helpful? Or you can ask for it and see, could a palliative care um, doctor or clinician. Um, I work on an interdisciplinary team. So part of what you're saying is like, what are you getting? So I can obviously speak most closely to my team. I work in the inpatient setting, so I'm kind of describing a little bit of what I do day to day. So I work part of a team. There's doctors, there's nurse practitioners, um, there are social workers, and we also have a palliative care chaplain. And so all of those folks are actually not only trained in their primary disciplines, but are also often receive additional training or have additional certification and expertise in palliative care as well. And so, um, to your point, I see a lot of patients for whom faith and religion is really important to them. And, there's many times where I'm like, I'm going to bring my team member tomorrow to visit, or I might send my team member. Her name is Sarah. We have two right now, Sarah and Katie, to come visit with you to talk about some of these things. And some of those existential questions are direct faith and religion
Yeah.
based, but
Yeah.
sometimes even if folks don't identify with a particular religious community, they might still be facing existential life questions or things that they might be facing in, when they're diagnosed with a
Right.
serious illness.
Right.
And so our chaplains are very well versed, kind of no matter what your religious, spiritual background is, or if you don't kind of identify with a specific religion, they can still help with some of these big life picture questions. And so some of what you're getting is kind of access to this interdisciplinary team, so to speak, in addition to, you know, me as a physician or one of my nurse practitioner colleagues helping support a patient. And so that's kind of one way to access it. Another care setting where you can access palliative care is in the outpatient or kind of the clinic setting. Now, outpatient palliative care is definitely growing, but it is not as widely available as it is kind of in the hospital setting.
Okay.
And so oftentimes I mentioned that palliative care really grew up. We're a younger field. Granted, we've been around for probably like 30 years, so it's not that young, but it's young in
Comparison to
medicine broadly,
cardiology, pediatrics.
comparison to
Yeah, yeah,
cardiology
yeah.
and lots of other things. We're young. Um, we grew up in kind of partnership with oncology. And so many palliative care clinics are actually kind of based or housed within a cancer center because that's kind of who oncology was the specialty that I would say was the first who was most excited and accepted and willing to partner with us. Um, and and so sometimes, so I would say, you know, if you're kind of part of a cancer center, if you have been diagnosed with cancer, it's something to talk about with your oncologist. You know, do you have a palliative care team? Might they be something that another team that could kind of help support? And so sometimes it is a little bit of this asking and self advocacy
Yeah.
to get access to palliative care. And I would say it's growing, but I think there's still definitely room to grow for how do we get kind of clinic palliative care access for folks who don't have a cancer diagnosis when so many of the clinics are based in cancer centers or
Mhm.
cancer practices and things like that. And so not all some some clinics will accept other patients who don't have cancer, even though they're within the cancer center. And also, there's kind of a growing number of clinics that are being set up in other places, like, you know, in partnership with cardiology or in partnership with other spaces. And so that's definitely growing. And you won't know might, what you might or might not have access to sometimes until you ask.
And so let's jump into a little bit because again, we've talked about disparities, awareness, and access. Again, one of the reasons we're talking about this today. And so are you aware of any additional limitations in accessing for BIPOC folks, in addition to what is usually sometimes the issue, cultural competency, or just someone thinking to name to a patient, hey, have you thought about this? If you're in oncology, if you have a diagnosis, percentage is probably high that someone's going to mention this to you. But if you have some other diseases, you if you're not aware, and I want to say if the physician just for whatever reason that day in an appointment doesn't remember to mention it, what are some of those, if there are limitations, even in this space, in addition to the regular sort of disparities?
Yeah. No, I mean, I think as you said, we can't ignore the like regular disparities, or
Yes.
sometimes, you know, disparities speak about differences, and sometimes I like to use the word inequities because I think there it's a little bit more specific than
Yes.
disparities, because
Yes.
inequities are disparities that are at times unjust,
Yep.
avoidable, and really just unfair.
You taught
um
me something away from palliative care today. So we're going to say, instead of, we're going to talk about inequities. That, thank you.
yeah,
Words matter. Thank
words
you.
do.
Yes.
And I will also say sometimes there is a place to say disparities because
Yes.
sometimes you don't know enough to know whether it's an inequity or not. I would say disparities is more of an umbrella term, and inequities is a little bit more focused.
Okay.
I feel like I'm making all of these like word trees
No,
here.
this is good. This is, and I did kind of imagine the little
Yeah.
line under. Go ahead. Go
Um,
ahead.
But, I think it's difficult to ignore the inequities in health more broadly. So for example, it is, there is information kind of in the literature that, for example, like Black and Latino individuals are often diagnosed at a more advanced stage of
Yes.
disease.
Yep.
And some of that stems from maybe inequities or disparities that exist in, for example, cancer screenings and things like that. It starts really early. And I know you've had other guests talk about, how do we begin to address some of those kind of upstream things, and some
Yes.
great work that, one of my colleagues, Dr. Flores, has done in terms of
Yes.
breast cancer screening and kind of community based mammography screening and things like that. Um, but so you can't ignore that. And so how it affects folks in palliative care is that sometimes Black and Latino individuals, well, first of all, I'll say I think a lot more needs to be studied because we have some limited data. But what we do know is that oftentimes Black and Latino patients are um, coming to their first palliative care visit often with more uncontrolled symptoms,
Yeah.
and that might be because their disease was more advanced before you caught it.
Yep.
Um, and that therefore that's where they are. And then, sometimes because you're already starting up here, like at a higher level with your symptom burden, we might not be able to get it as low after one visit or a couple of visits, but it's a partnership. It's a work in progress and we can get there, but you kind of got to like stick together, because if you're starting up here, there's just more work to be done to get you to a place where you're more comfortable. So I will say, I am a huge fan of palliative care and all the work that my amazing colleagues and team members do, and I just want to be honest too, we're not miracle workers. Like one
Yes.
visit with palliative care will not solve
Mhm.
everything. It is a partnership and working together and taking sometimes baby steps towards helping you feel better. But hopefully, I think, what my patients get excited about is I've got someone in here with me. I've got someone at my side who's going to
Yes.
help me get to that place where I'm feeling better.
Absolutely.
And so there, in the inpatient setting, there's kind of mixed data. Sometimes they say folks are Black and Latino patients are actually more likely to get an inpatient palliative care consult, and there's a lot of different reasons for why that might be that I would
Mhm.
say we still have to further explore. It might be because there are um, differences, or that the primary team can't figure out or find the right ways to connect, and they're kind
Yeah.
of calling for help earlier from a palliative care, because the other thing in palliative care, we're communication specialists,
Yeah.
across other
Have to
other
be.
doctors and
Yeah.
clinical teams, and with patients, families, and loved ones. And so sometimes they're kind of calling for that extra support earlier. But sometimes it's, I think kind of goes back to a little bit of that self advocacy too, that if, which is why I'm like grateful for this opportunity to be on your show, because I want other folks in the community to know this is something you can ask for. This is something you can ask about. And it may not, always be possible to get. And you're totally right. I don't want to be dismissive of other costs that might be associated with
Yeah.
things like clinic visits or things like that. But for example, I'll talk, and this is just the setting that I'm most comfortable with. When you're in the hospital, yes, there are charges and things like that.
Mhm.
Um, but getting our help isn't all that different from if your medicine team, for example, thinks you need um, a cardiology consult to get
I was gonna
specialty
say
input
consult.
from
Yeah.
cardiology.
Yeah.
They can just the same ask for a palliative care consult and
Mhm.
get palliative care on board too.
It's so this information is so needed. I'm looking at some of the contents, and Heidi Ivy is saying she learned during my brother's transition. You have to have stuff in order so your family isn't left making hard, life altering decisions. And I think, again, not to be morbid or
Hmm.
anything, but a lot of my audience are um, a little more seasoned, or are caregivers,
Hmm.
or their parents are at ages where they may be dealing with either regular sort of end of life, or chronic diseases. And so one of the things that I'm seeing in some of the comments here, that Lasagna is saying from Brockton, it's so crucial to have these conversations while family members are healthy And to have a healthcare, let's name that a healthcare, yes, Lasagna, a healthcare proxy, it makes it a little easier to make decisions in an emotional and difficult time. And though palliative care is not necessarily hospice, this space can sometimes bring about certain emotions because you do have to consider some of the toward end of life happenings and
Yeah.
decisions that, and it's a reality. It's a
Yeah.
reality. Being 51, I didn't think about it as much as 31. Now, at least once a month or whatever, I think about more my mortality. And it's a real, we're smiling, we get through these things with, laughter and joy, but it is a reality. It really is a
Yeah.
reality. And I think one of the things that you would agree with is that away from the patient, we also, this information is important to the caregiver because I believe that this space and specialty to some extent supports the caregiver because they're not having,
Absolutely.
give me an,
Absolutely. No, I mean, I love these comments, Heidi and Lasagna, I think it
yes,
was. Forgive me
you're
if
good.
I misspoke your names, but
Got it.
um, I love those comments, and this gets back to what we touched on a little bit earlier of like advanced care planning. And a lot of times, I think um, advanced care planning is this term that kind of talks about a couple of things.
Yep.
First of all, it's having conversations with your family and loved ones about the things that are important to you and maybe what your own wishes are, such that if at some point you lose your voice, you mentioned the word incapacitated, or if, something happens that you're no longer able to speak for yourself. Number one, you have named the trusted person, your healthcare proxy, who's going to help be your voice in that moment.
Yep.
But number 2, really importantly, that you've had conversations with that person so that they don't feel like they're burdened having to make decisions entirely on your behalf, but that they're making decisions that reflect what's important to you and what your values are. And they can't do that unless you've had conversations. And so that's one of those things that in some ways it feels like it's never too early to be having these conversations. It's better to have them when you're healthy. It's better to have them anywhere but in the heat of the moment of a crisis. Anything else. And having conversations, some of these things, it's kind of about building a skill. They're not one and done conversations.
Yeah.
The
Yeah.
things that you feel like, you know, Jimmy, you at 31 thought were important are probably not exactly the same things that you at 51 think are important, that are probably not going to be the exact same things that you in 10 years are going to think are important. And so sometimes it's about kind of continuing to have these conversations. And so sometimes I worry people are like, oh, it's a checkbox. Once I've checked that box, like I'm done. I'm like, no, it's about continuing to know who you are as a person and continuing to have some of these conversations with your doctors, because in some ways it's actually a gift to your proxy, to your family members, to your loved ones, to know that they're making decisions that you would have made for yourself so that they're not feeling the burden of like, it's on me to decide, or as Lasagna said, to make a life altering decision. So, in some ways, advanced care planning and stuff is actually a gift to others to say, I'm putting on paper, these are the things that matter to me. This is what's important to me. So that if at some point, God forbid, be you in a car accident or something in 5 days or in 5 years or whatever, if you haven't had a chance to talk about it necessarily and something happens urgently, people can like look back and refer of like, you know what? I talked about this
Mhm.
with my person a while ago, and or maybe sometimes it can be conversations that were like triggered on the news or seeing this or seeing that, and you're like, I know what they would want in that moment because we've talked about it. And suddenly it doesn't feel as hard to make a decision, whatever that decision may be, um, because it's their voice coming through. And that's often one of my favorite things to say of when I'm having a conversation, or let's say someone's in the intensive care unit and ill and not able to speak for themselves. I might be having a meeting with family members and I'd be like, what if Sarah, and I'll just say Sarah is my
Mhm.
patient. What if, you are the ones who know Sarah best? I didn't have the opportunity or the gift of meeting her before her illness. What would Sarah say, or how do we bring Sarah's voice into this meeting
Yep.
now? And we can only do that through you, her family member and loved ones who know her best.
Absolutely. I wanted to bring up that point that you were Lasagna is I will name Lasagna's been very public, good friend of mine who coming up in August, I believe 2 years ago, had watched her husband probably deal with this care and hospice as well. So she's speaking from life experience. It is a reality. And we as a culture, a lot of black and brown folks, either don't want to deal with or really don't know their rights or options. And that's such a double-edged sword there, because in our culture, in any culture really, humanity does not willingly want to talk about their mortality or end of life. We, depending on your
Mhm.
age, some think we're going to live forever, and some are facing reality that you're now on the other end of now sort of, I can't wait to get to this age. And to now we're like, ooh, this other age is approaching soon. But in all seriousness, every health ailment does not lead to death. And to your point about it could be a car accident on the opposite side of this. Every health ailment does not lead to death. And even if it ultimately does, you can reflect the person's wishes without guilt. To your point about not having to go through the emotional, mental of in the moment and in crisis. And I know we were talking really about care here, but there is a care that we must consider for the caregivers
Mhm.
that have the awesome responsibility, again, not even incapacitated, but just a 3-day bout of severe nausea and you just can't. You need that caregiver. So those of you that are watching that have, you know, either maybe chronic diseases or have had the thought about, I'm not as young as I used to be. I'll be very transparent. My mom might get me. She's watching. My mother recently had a hospital stay. Kind of scared us because if we didn't catch it, the doctor said she would have swole up and cut off her airway. And so I said to her at the house, I said, Ma, and I prepped it. I said, at some point, we got to start having a conversation. If I'm 51, then mom is, a little bit more up there.
More than 51.
Well, you did that real well. But it is a reality. And again, we were talking about care here, but this is a touch point that I think we need to just reiterate that the patient and the caregiver loved one needs to have a conversation to make sure that wishes are known from going into palliative care if you become incapacitated, your wishes about hospice. And speaking of that, I don't know if
Yeah.
Auntie Paula is still here. And we did kind of touch this a little bit, Auntie Paula, but just to reiterate, isn't outpatient palliative care also referred to as hospice, or are they different? And yes, we did find out there's a little difference. We had hospice care at home for my dad because he did not want to die in the hospital. So there is that flexibility as well, or right?
Yeah, and so just to touch on that, we talked
Yes.
about earlier, there's inpatient palliative care, there's outpatient palliative care that's based in the clinic. There's also some home-based palliative care, which I'll say is
Wonder.
much smaller. And so MGH has one of the programs. Again, that's where I work, so that's what I'm most familiar with. But we are not the only.
Yep, yep, yep.
But there aren't as many of the home-based palliative care that does come kind of into the home, but home-based palliative care is different than home hospice. And so home hospice is, again, focused on those who are a little bit closer to the end of life or kind of estimated that, 6 months or less. And so the hospice team that comes into your home is different than, what we might call about the home-based palliative care team, which might be, again, accompany you in this journey for potentially years. And so the types of supports that you get with home-based hospice, there are some similarities, some of that kind of interdisciplinary
Yep.
teams, but the support that you get with home hospice is um, more intense, and I would say you have more resources available through home hospice than you do, say, through a home-based palliative care program. Because, for example, one of the things that's different is you have this kind of 24/7 hotline, which is
Mhm.
honestly a lifeline for many. Because I think
Mm.
for folks who are on home hospice, many of them, as Paula said, have this hope of they wanna be dying at home. They don't wanna
Yep.
be dying in the hospital, and so one of their main goals is to not go to the hospital.
Yeah.
And what happens is these patients are ill, symptoms might occur, something might come up. And that's why you have that 24/7 hotline that a nurse will answer no matter what time of day if you're enrolled in hospice services, because they're there to support you, the patient, you, the caregiver, in making sure that you have the medicines that you need or something. And that's why a lot of the burden of providing hospice care really is on family members and loved ones at home, but you're also not alone. That's why you have this hotline to call and say, okay, this is what I'm seeing, I don't know what to do, I'm not a doctor, what am I supposed to do? And that's why the nurse is there on the phone to say, okay, remember these medicines that we put in your fridge, it's time to pull that packet out and use this amount of this medicine. And they'll coach you, if you're seeing something new, to try to help them to feel better so that you can avoid unnecessary trips to the hospital that, aren't really helping or focusing on the things that are important to that individual at that point in time.
I just and it kind of hit me. My grandmother came home and wanted not to go to the hospital. And I remember she was in pain. And I was a little concerned because she had I think it was morphine
Mhm.
patches. And I was not just slapping a whole one on her. So I don't know if it was a hotline, but I remember calling and getting sort of that access to say, hey, my grandmother's not feeling well. She's in pain. Do I cut it? Do I give her the whole? And they let me know that it was okay to put the whole patch on, but it just hit me when you said that, to remember that. And so this was
Yeah.
so more enlightening on a few levels than I had expected. We talk about care and protocols and
Mhm.
disparities and everything that we usually do in this space, but I think that it just was great for folks to hear this information. Of course, those of you that will watch in the after watch, still feel free to comment. The other thing is, and this is just my question as we started in COVID and very familiar, it must have been very interesting for your specialty during COVID.
Mhm.
Not, long, you didn't know, but what was, if you don't mind, as we get ready to close out, we answered Paula's question. I believe that was the only one that we had. And I don't know if you noticed, Paula did say that she's clear
Yeah.
and has it now. So awesome. Listen, that's the goal. As we get ready to wrap up, how did COVID influence palliative care? What was it like in COVID?
Yeah. So, I mean, I think, if we rewind to what was life like, March, April 2020 here in Boston, as
Yeah,
probably only second to New York, we had the second biggest wave in the US, especially that early, where
from
there
the
was that
onset.
much
Yeah.
unknown.
Yep.
And so, I think in many ways, one of the things that by necessity palliative care clinicians get good at is trying to support people through uncertainty,
Hmm.
because tolerating uncertainty can be really hard for anyone.
Yep.
Um, and so that's kind of one of the things that is, um, part of what we focus on in our specialty and support patients and families through, and even sometimes teams through. Um, and COVID uh, amplified that like
Yeah.
times a million, because, we have some experience or have, um, a sense of, if someone has X type of cancer and isn't responding to Y type of treatment, we might have a guess of, okay, well, we think that this is what that might mean,
Mhm.
with our best guess of prognosis or kind of what lies ahead, be it in terms of time, in terms of function, or things like that. With COVID, it was so hard to know because nobody knew. And so suddenly it was really humbling in some ways as a palliative care clinician, because all of us, be it in medicine or not, I would say like all of us in society, were now forced to tolerate a new degree of uncertainty of what this new novel illness meant, what it meant for a family member or an older family member to kind of get COVID. Um, and and there was it was humbling in many ways to feel a lot of that I had some experience trying to coach patients through, but you don't know it until you feel it. And so,
I
yeah.
appreciate, and I'm very observant. And I had maybe asked that question as a thought. One, I approach it if I'm thinking it, maybe somebody else in the audience was, and I just want to name that that was a very sensitive, question as we move in the space of mental health here in your Healthy Java. And so I want to just acknowledge that I noticed a difference in cadence when you were answering there. And so, Dr. Kareen, I just want to say thank you for being transparent. Thank you for being the advocate that you are in this space for our patients, period, but especially as a Latina woman. And I'm not letting it go that you referenced to the two chaplains that were
Yeah.
women. So let's
Oh,
just name that.
I
Um,
was gonna say, I was like, Jimmy, if you have, uh, I have other ideas if you want to do other things. Because one of the things that you were talking about, or that's come up a lot for some of my patients who are very faithful, very
yes.
religious, is oftentimes they view disease or view things in the context of, hope for a miracle. And there's a lot that you could have a whole separate um, visit on what
Yes.
does it mean to hope for a miracle? How do you support patients who are hoping for a miracle? And how do you think about making medical decisions in that
In the
context
faith
of
space.
of
Woo.
hoping for of hoping for a miracle? Because I'll just say, I'll take 2 seconds to say, a miracle can mean a lot of different things to different people.
Yep.
And sometimes it's about just exploring what does it mean to you, and also um, remembering that decisions that you make, decisions that your family members make, decisions that clinicians make will never interfere with God's ability to conduct whatever miracle he feels is right. And so I often find myself encouraging, maybe I'm giving away too many pearls for a
You're
future
good.
your future episode here, but
No,
will
no, no, no.
never deter. And so I always try to encourage my patients that making decisions or having discussions is never a reflection of a lack of faith. It's simply making decisions with the best information that we know, and we continue to have faith that no matter what decisions we're making will not stop God from doing whatever is in his plan. And
Absolutely.
sometimes his plan may not be what we think or what we want,
There's the
but he
miracle.
does things for a reason.
So you done snuck another preach up in here. Listen, because I've seen stories. I've never heard it in the hospital, not that I remember. But I've seen movies and shows where the doctors say, we've done all we can do. It's in hands higher than ours. And so there is context there in the medical industry of faith, belief, and everything like that. So it's interesting because usually my gauge of a good session is that I'm tired. I'm not tired, but I'm like, just the information that went out, I'm kind of like exhaling, like, this is good. Because we need to know this information. And again, thank you for your transparency when I asked about COVID. Thank you for just your sincere passion in this space and making sure and know that either through your Healthy Java or Java with Jimmy Regular, we're going to go down that path of faith and medicine, because Dr.
Mhm.
Ron K has talked about it a lot. We also, in the faith space, sometimes how some leaders of faith or people in the faith space have viewed certain sicknesses in more of a spiritual place versus dealing with the physical. And so that's a whole, thank you, because that's a face-to-face panel with a couple of people, because that would
Oh yeah.
really, yeah, we need to work that out.
I
So
will say Reverend Gloria White Hammond is one of my favorite
oh goodness, I was just gonna say
humans.
this. Yes.
She's
Yes.
one of my favorite humans, and I feel like she's spent time and had a desire to learn more about palliative care and kind of bringing it to her faith community as well, of kind of
Okay.
some of these concepts of advanced care planning.
Yes.
And so I think there's real partnership opportunities available of kind of working with, because that's some of the point of healthcare too, of think about for Black and Latino and other communities, other Black and Brown communities. It's about meeting people where they are
Yeah.
and partnering with people in whom they have trust. And for many folks, that's faith communities.
Yeah.
And so partnering and making it feel it's not scary to engage in these conversations. It's
Mm-mm.
not scary to have this type of support. And in no way does it reflect a lack of faith.
Not at all. And I will say, on the other side, as a person of faith, people of faith also need to be faithful or have faith in the fact that these physicians, nurses, caregivers, and doctors have trained. And I always compare it to similar to a mechanic. They are fixing a car. Our nurses, doctors, physician assistants, got to give a shout out to the admin and the environmental services as well that are part of the system. They're important for fixing us as humans. And so my suggestion is have faith and you believe, you consult with your doctors and you take that prayer and say, according to the doctors, X, Y, and Z medicine is going to, may do this. So we're praying that it has an impact. Because as you said, miracle thing here. So I appreciate you so much. I'll follow up with you about this faith in medicine thing. I'm going to go share, and I don't know if you saw the tweet yet, but I'm getting ready to announce that we are naming our health fair on May 20th after Joseph R. Betancourt. And so it will be known as the Betancourt Health Fair starting this or next year. But I'm going to go talk about that a little bit. And if you're free on the 20th, please come by. I'm going to make sure I get emails out and invites to everyone. But thank you so much for spending time with us today and ensuring that caregivers, seniors, those with maybe chronic diabetes. Oh,
Uh-oh.
did we get
You froze on me a little, Jimmy.
okay, I just seen something. Oh boy. All right, I just seen something with the Wi-Fi. So I just basically said thank you.
Right.
And we'll go ahead and get off of here before it cuts us off.
Sounds good. Thanks so much for having
Thank
me
you
today,
so much.
Jimmy.
All right.
It's a
Bye-bye.
delight. Bye.
Guys, I don't know what's going on with the signal. Let me know if we're still here. But I just wanted to remind you on May 20th, we're having the Your Healthy Java Joseph R. Betancourt Health Fair. This is taking place on May 20th. I'm putting the flyers up, so I'm going to get off of here since it's a sign of technical difficulties. Have a good day, everybody, and thank you very much for joining today.